Hi everyone and welcome to today's webinar. I'm Amy Duncan, I'm part of the Transition Support Project team and I'm going to be facilitating today's session, and I'm joined by Associate Professor Tania Shelby-James, who is the manager of our project. I'd like to start by showing my respect to elders past and present and emerging, and to acknowledge the deep relationship of Aboriginal and Torres Strait Islander peoples to country and their role as traditional custodians of these lands. I'd also like to acknowledge the consumers and carers who have lived with mental illness in the past and those who continue to live with mental illness in the present. So the Transition Support Project has been asked by Western Victoria PHN to develop this webinar to assist GPs and other clinicians who wish to know more about the NDIS and their role in assisting someone who wishes to apply for the National Disability Insurance Scheme. Transition Support Project is based within the discipline of General Practice at Flinders University, and we've been supporting mental health providers to understand the NDIS since 2016. This webinar is for clinicians to help you understand the NDIS and your role in supporting your patients to join the NDIS. The presentation has been developed in collaboration with the Western Victoria PHN for their clinicians, however the content is relevant right around Australia. I'd like to hand over to Tania now, who will start by giving a presentation and then we'll finish off by addressing a few common questions.
Thank you, Amy. So what we're going to talk about today is really what the NDIS is and what supports they provide for people with psychosocial disability. We're also going to talk about which patients are most likely to receive support from the NDIS, how the NDIS supports vary from the supports that you guys provide as mainstream clinicians. We're going to talk about the pathway for someone who wants to access the NDIS, and then your role in helping someone with that pathway and how to do that efficiently and with the least amount of time for you guys in the busy surgeries. So we'll start off. First of all, what is the NDIS? It has been around since 2016, so most of you will have had quite a bit of interaction with the NDIS, but it is always good for people who are just starting off with NDIS to remind ourselves about what it is. So the National Disability Insurance Scheme is a nationwide scheme that supports people with a permanent and significant disability. It provides support for, when it's in full rollout, it'll provide support for about 460,000 Australians under the age of 65 with permanent and significant disabilities. The support it provides will be to allow them to live the same sort of life that somebody without a disability is able to do, and allow them to fully participate in our society, both economically and socially. When it comes to people with mental health, there are about 600,000 people in Australia who have a mental health condition. Of those, about 290,000 need support either all the time or periodically. And of those 290,000 people who need support for their mental health, about 64,000 people will have the type of mental health that leads to a psychosocial disability and will be most likely to benefit from the NDIS. So when we're talking about psychosocial disability moving forward, just remember it is for that more complex cohort of people that you see with mental health. So what is psychosocial disability? So we've alluded that, so as I've said, there are about 64,000 people who will have psychosocial disability and complex needs that will mean that they're likely to get into the NDIS. So not everybody with a mental health condition will have a psychosocial disability. Psychosocial disability is a term used to describe a disability that arises from a mental health condition. And it can result in things, the difficulties or the disabilities that arise might make it difficult for them to do everyday tasks such as banking, shopping and taking care of themselves. For some people, they may struggle a little bit to interact socially, but for people with psychosocial disability, their mental health may make it so difficult for them that they become socially isolated, they have no friends, they're unable to interact in society like the rest of us would do who do not have this psychosocial disability. That's the group that the NDIS is targeting. On the right-hand side, you'll see a quote from Debbie Hamilton, who is a carer as a consumer rep for the NDIS who has a psychosocial disability, who sort of explains for her what it looks like for someone who has psychosocial disability. So they will generally have experienced more than one involuntary admissions. They may have been arrested by police. They may struggle to maintain their home. They may not be able to manage their own finances and have a guardian in place to help them manage everyday aspects of their lives. I really want to flag for people when they're starting to understand what psychosocial disability looks like and how it interacts with the NDIS. You really should have a look at the mental health on the NDIS page on the NDIS website. It's a really great resource. There are a number of different publications you can download. There is a video from the mental health team within the NDIA that talks about what psychosocial disability is and how people with psychosocial disability may need support from the NDIS. So I do recommend you go look at that one. So for people, for someone to access the NDIS, what they're looking for is long-term support. And they need supports that go beyond what is considered to be normal to carry out everyday tasks. The NDIS looks at 6 areas of a person's life, and to get into the NDIS, the person needs to demonstrate that they require substantial support in one or more of these 6 areas. So communication. Now communication really does relate to the ability to be heard and to be understood. Often people with mental health issues may report that they have communication issues. They find it difficult to talk to people, or they interact inappropriately with others when they are communicating. They're technically not communication issues. They go more to the next one, which is social interaction. This is an area where people with psychosocial disability do have substantial difficulties. So social interaction is about the way in which people interact with each other. And so people with a psychosocial disability often find it difficult to have productive interactions with others. They may, the way they speak to people may be misunderstood. They may have difficulty making people understand their points of view, or they may not understand other people's points of view. So this is definitely a significant impairment for people with psychosocial disability. Learning goes more to intellectual disability. So not such a big impairment for people with psychosocial unless they have more than one disability. Mobility is around use of limbs. So this is the people who are unable to use their arms or legs. They're unable to walk because of their disability. They may need assistive technology to be able to get around, to be able to write, or to be able to be mobile in the community. Self-care is another area where people with psychosocial disability will experience difficulties. This is the ability to take care of yourself, to maintain your hygiene, to take medications, to remember to eat appropriate foods, to be able to dress yourself appropriately, to have clean clothes, those sorts of areas. And often people with a psychosocial disability will have family or carers that support them in this area. And the final one is self-management. That's the ability for someone to be able to manage their life. Typical impairments that someone with a psychosocial disability will experience in this area include tablets, forgetting to take medications, forgetting to pay bills, struggling to maintain tenancy, those sorts of things. And again, this is another impairment that is common for people with psychosocial disability. When we talk about, when we come to it later, we're going to be talking about treatment options to resolve the mental health issues. We're going to be talking there about clinical recovery. So we will touch on that a bit more in the following slides. As I said before, the areas of social interaction, self-care and self-management are the 3 areas where people with psychosocial disability will be more likely to struggle. I want to quickly talk about the NDIS and the mental health system. There is often a perception that the NDIS will duplicate what is done in the medical system, and that's not true. They're both designed, the NDIS is designed to sit alongside the mental health system. So the mental health system will provide, is responsible for the diagnosis and treatment of the underlying mental health condition. This includes acute care services, so when someone has a psychotic episode and needs to be admitted to hospital. It includes early intervention therapies, it includes treatments and medications for the underlying mental health condition. The NDIS, however, will provide funding to address those impairments or those challenges that arise because of the mental health condition. For example, if someone struggles around self-care and maintaining their home, they may put in some supports to help them learn how to take care of their home, how to keep their house clean, how to keep their yard clean. If they struggle with taking around self-management and taking medications, they might implement a medication management training. They might also have some prompting to help them to take medications as well. And if someone is socially isolated because of their mental health condition, the NDIS can put funds in place that will help them go out and access the community. We'll have support workers to take them out. They might be able to go to some funded group activities. They might be able to explore new hobbies and meet friends. I now want to talk about access. So this is the area of the NDIS that you will be asked to help people with. So you'll have people coming to you who want to access the NDIS, and providing evidence to support that access application is crucial and is something that you need to do. So when it comes to access to the NDIS, there are three main access criteria. The person needs to be under 65 when they begin their access application. They need to be an Australian citizen or a permanent resident. And the third one is that they need to meet the disability requirements for the scheme. That is, they have to have a disability that is permanent, significant, and has impairment. So the boxes that you see, A through to E, are the 5 categories that sit within the disability requirements. And to enter the scheme, a person must meet all 5 of those. We are now going to talk only though about the first 3 because these are the main criteria. If the person can show that they meet all 3, usually they will meet the last 2. And when it comes to your role in access, you only need to worry about the first 3. So this is what we'll be focusing on for the rest of the presentation. Okay. So the first thing we're going to talk about is likely permanent disability. So to get into the NDIS, this is in criteria number A. To access the NDIS, the person needs to demonstrate they have a disability or impairments that are attributable to a psychiatric condition and that those impairments are likely to be permanent. This is the bit that needs to come from someone who is clinically qualified to make that, to be able to say that. So the first thing is there a mental health condition present? You do not need to have a diagnosis to access the NDIS. The legislation does not talk about providing a diagnosis. You need to provide confirmation that a mental health condition is present. However, to be honest, if a person has a diagnosis, it is really good to put that information into the access request because it does help. So what you need to be able to provide is confirmation that there is a mental health condition or diagnosis present when that was diagnosed, and that it results in impairments that affect a person every single day of their life. The second thing that you need to do is provide confirmation that the condition is likely to be lifelong. That is, despite all treatments that they've tried, there are no other known, available or appropriate treatments that are reasonable for this person that will remedy the impairments caused by the mental health condition. So what sort of evidence do you need to prove to be able to meet those 2 criteria? It sounds quite daunting. So the first thing is that To provide the evidence, you usually need to have someone who's suitably qualified to do so. So that is usually a psychiatrist or a GP, someone with the qualifications to discuss treatments and expected outcomes. Often it is GPs because they are the people that people see the most when it comes to their mental health condition, and usually it's the GPs that will be prescribing and monitoring the medications. So that's why you guys are such a great source of information. So you'll need to, on the evidence form, be able to provide a list of all the medications and treatments that the person has tried and what the outcomes of those were. When you're providing information around treatments and what's being done to try and relieve the mental health condition, you need to think about how consistent is the evidence. And are there any reasons that further assessments might be required? Sometimes for a certain mental health condition, there may be really great evidence around a particular treatment. For example, electroconvulsive therapy. However, for the person who lives remotely, they may be unable to access that treatment because they would need to travel into a metro city. And for that person, it may not be reasonable. So I think if you know that there is a treatment that could be tried but is not being tried, you need to provide an explanation for why, for example, ECT has not been tried. The other important thing when looking at likely permanency of a disability is how old the person is. Often we see applications come through and we hear about applications where the person is only 18. So they've been diagnosed with a significant mental health condition. They may have had, been struggling with a mental health condition for 2 or 3 years. And it's quite extreme and it's got a lot of impairments associated with it. But when it comes to likely permanence, the NDIA will look at time since diagnosis, and if it has been less than 2 years, they would really need to be able to have very strong evidence that all treatments have been tried and all treatments did not work. Usually they would say that it takes a few years for all treatments to be tried. So when you're providing your evidence, thinking about that is important as well. So the second piece of evidence that you might be asked to assist with is substantially reduced function. How do the impairments that result from the mental health condition affect the person every day of their life? To be considered substantial, what this means is within one of those areas that we talked about before, those 6 areas, the person is unable to do most activities without support. That is, if they struggle around self-care, if they didn't have anyone with them to help them, would they be able to take care of themselves? If they didn't have their mum or their partner prompting them to get out of bed every day, eat breakfast, get dressed, get up, would they be able to do that on their own? You need to be able to show that without support, people are unable to function in one or more of the domains. And those impairments that you talk about, being unable to get out of bed, must be related to their mental health condition only. Luckily though, the evidence, the form that you'll be asked to fill out has already been, the section around impairments will have already been filled out by a support worker or the person themselves, and you do have the option of just reviewing that and actually saying, yes, I agree with what's been written. However, if you know the person really well, you are also very welcome to write some information about this as well. But commenting on the substantially reduced function can be optional for you. So the evidence that we might want to provide around how to demonstrate there is substantially reduced function. When you get an application in, it will have a support worker letter already with it that'll talk about how the person struggles day to day, so that'll give you a really good overview of how the person is struggling. There will be a life skill profile 16 or a HUDAS completed. These are functional assessments that have been validated in large populations and provide a very robust, objective picture of how the person is functioning across the various domains. The life skill profile 16 is specific to mental health, and was developed in Australia, so it's a really good tool. So that would be the recommended tool. You may get some carer statements where the carer can talk about what they do every day to support the person with the mental health condition. Sometimes even people might want to put a personal statement up, so there might be a written statement from the person themselves about how their mental health condition affects them. And if a person has already had an OT assessment completed, sometimes that can be a really good source of evidence as well around substantially reduced daily function. All right, so now what we're going to talk about is the pathway of how someone accesses the NDIS. Now, I know that this is a very, very complex diagram, and you will be provided, there are some resources that you can access that will have this in printed form. But what I really wanted to focus on with this is the general practice is the third row down. So what will happen is the person who seeks to access the NDIS, when they want to get the clinical evidence from you, they are directed to ring the practice and book a double appointment with the practice to come and see you. And before they come to see you with that double appointment, you will have been sent the evidence forms partially completed by the support worker. So you'll get the evidence of psychosocial disability form, you'll get the support worker letter, and you'll get any other evidence that the person thinks is relevant to their access application. You'll be sent this before you see the person, so you'll have time to read through it and you'll be able to see what areas you need to fill in. The section that you need to fill in, some of it can also be completed by practice staff, so you may want to get practice staff to complete those areas. You will then sit down with the person and talk about, during the appointment, you'll sit down with the person, might want to confirm some of the treatments and how they're going. You may also want to have a quick chat about how their life is looking and the impacts of their mental health condition, just so that you can then review what the support worker has done and see if you agree. And then at the end of the appointment, the person will take the form away with them and submit it. And that is it for your role in access, unless the NDIS ring and ask a few clarifying questions. So what I want to do now is just quickly talk about the form that you will be sent. So this is the evidence of psychosocial disability form. It looks very different to the access request forms that you may have done in the past. This form has been developed by our team in conjunction with the NDIS and it's specifically tailored to psychosocial disability, taking into account a lot of the barriers that face general practice when it comes to helping people access the scheme. This form guides the clinicians through the evidence they need to provide, and the version you're seeing on screen now has been marked up by Western Victoria PHN to indicate which parts of the form the GP needs to fill out or which parts of the form other members of the practice can complete on behalf of the GP. And you will have access to these resources through the Western Victoria PHN health pathways that you can all access. So the important thing is you need to fill out section 1 of the form. You will get the form with section 2 already completed. Section 2 is the bit that the support worker has done that talks about the how the person struggles every day with their mental health. You will also have had a completed LSP 16, which is part of the form, so you'll be able to see the domains that the person struggles in as well. So section A of the form, which you need to fill out, has information around diagnosis, around all the treatments that you're aware of that the person has tried and what was the outcome of those treatments. Remembering that treatments is not just medications, treatments can also be psychosocial treatments, and psychological treatments. There is a bit where you need to talk about a statement of permanency. What this means is once the diagnosis, the treatments, the hospitalisations have been filled out, you need to make a statement to confirm that despite all treatments, the mental health condition persists and is likely to persist for the person's lifetime. The NDIS require that written statement from you. And then the final part of Section A is a section where you can, if you wish, document the impairments that you're aware of that arise from the mental health condition, or you can just tick a box that says, I've reviewed Section B and I agree with what's been written by the support worker. When it comes to completing the form, things such as diagnosis, treatments and hospitalisations, you can definitely get someone else in your practice to complete those sections for you, and then you can just review them during the meeting with the patient. Okay, so I just wanted to finish up talking about some tips about providing evidence when you're completing the form. It's really important that you know that the NDIA doesn't make clinical judgments. They're not going to look at the evidence that you've provided on the form and question whether the right treatments have been given or question why a significant treatment wasn't tried. They are going to take the word of the clinician who fills out the form. And there was an AAT, the Administrative Appeals Tribunal, recently looked at a case where a person with psychosocial was denied access to the NDIS, and that really highlighted the role of GPs in providing evidence, and the evidence from the GP actually overruled the finding from the NDIS. So the role that you guys have in providing clinical information is crucial. It's really important to provide information about diagnosis, not just what the diagnosis is, but who provided the diagnosis and when the diagnosis was provided. If there is supporting evidence from a psychiatrist or another GP included in the access application that recommends a treatment, and then there's no information about that treatment in the information that you provide, the NDIA are likely to come back to you to ask for further information about why that treatment wasn't tried. So if you do see that there's additional evidence attached to an application that recommends a certain treatment, you will need to say if that treatment's been tried and what happened, or if that treatment wasn't tried, why not? Person doesn't have to have exhausted all treatments. There can be treatments into the future that may be tried, and that's fine because often people will be on treatments or will be trying new treatments into the future, not to cure their impairments, but to maintain their level of function so they don't get any worse. That's fine, but you may want to make a comment about that. So if a person is on a treatment and it's an ongoing treatment, you might want to make a statement about outcomes, that it is maintaining level of function rather than improving function. It's really important that you focus only on the mental health conditions and not co-occurring conditions. We know that people have, most people on average have at least one or two other co-occurring conditions. More than 50% of people in the NDIS have co-occurring conditions, so it is very common. But when it comes to access, you need to provide information only on the mental health condition. Otherwise, it just gets really complex and the NDIS can't tease out which impairments are related to the mental health condition and which impairments may be related to other co-occurring conditions. Language that you use is really important, and there are some words that you should probably avoid using, such as when you're talking about therapies, talk about therapies that are unlikely to improve function, or that they may prevent further declines in function. Words such as lack of motivation, is non-compliant, would benefit from, they all would make it look like the position may not be permanent, and if they were more compliant or they were more motivated, then the treatments may be more effective. So try to avoid words that indicate a choice in taking or complying with treatment. And do not mention any supports the person could benefit from. There will be lots of supports if they get into the NDIS that will give them benefits in terms of addressing the impairments. But when it comes to access, it is all about the impact of the mental health condition and what they cannot do because of their mental health condition. Talking about likely benefits from support makes it look like it's not a permanent impairment. So supports are really important, but we talk about them at planning once the person is in the scene. Another thing is that as a GP, when you're treating someone, you see the person as a whole. You know, GPs have a very holistic way of treating people. And this is great. This is one of the strengths of general practice, is that the person is seen as a whole and they're not just their disease. But for access, this can be very problematic, because looking at things from a holistic whole of person perspective means that the NDIS has a really hard time at access trying to tease out what is directly related to the mental health condition only. So it needs to be very focused on mental health only. If you start talking about any other health matters, for example, their diabetes and their non-compliance with their diabetes medications, which is leading to a bit of issues around weight gain and mobility, which may also make their mental health condition worse because they become a bit depressed about it, that will mean that an access assessor will contact you and they will want to try and work out what's going on. Would they still be depressed if they didn't have the diabetes? So by bringing in health matters, you make it all the more complex, and you are more likely to get a phone call from the NDIS to be able to unpack the mental health conditions from those associated health conditions. I know that providing evidence can be quite time consuming at times, and in general practice you are incredibly busy. There are some ways that you can reduce the amount of time it takes, and we have sort of talked about them a little bit throughout this presentation. You can have practice staff complete parts of Section A. You can get them to download the treatment history and just attach it as a staple to the form. You can get someone else to fill out the sections around hospitalisations, current medications, and patient information, including who and when diagnosis was made. They can be taken out of the person's medical record by someone else. You do not need to complete a full description of all the impairments that the person is experiencing because of their mental health condition. That has been done by the support worker. You can read that letter and just tick a box to say you agree. Of course, if you do not agree, you can take time to fill out the boxes if you wish. So I think we sort of have covered the basics of access. We've had some questions asked of us in the past. So what we'd like to do now is just go through some of those.
Great. Thank you, Tania. So as we've talked about, there's quite a lot of information that the GPs provide, particularly around someone's history. How would you advise a clinician who's new to the surgery and perhaps doesn't know the person that they're being asked to review for access, and all of a sudden they have this form ready to go, and they're being asked to provide a lot of detail? So what kind of tips can we give for clinicians in that situation?
Look, I think this will happen a lot, particularly when people are quite transient. They move from place to place, and also GPs come in and out of practices. So if you are being asked to fill out an access request with someone that you don't know very well, but they have been going to the practice for quite a while, you will have access to their mental health. You will have access to their medical records. You can review those medical records. And what the idea is, using your clinical knowledge, your training, for a given diagnosis. So if this person has schizophrenia, for example, you've got the diagnosis, you've got a list of all the treatments that have been tried for that person, and look at, knowing what you know about schizophrenia and the etiology of schizophrenia, do these medications seem adequate? You know, is this the sort of treatment that you would expect to see? And then when you meet with the person, just talking through those treatments, what happened, why didn't it work? What are you on now? How's that going for you? So really, as long as you've got the full access to their medical records and you can use your clinical judgment and your clinical expertise, you will be able to comment on whether the treatments that have been tried are appropriate. if there was a treatment that you know of that wasn't tried, you might talk to the person about why they didn't do that treatment, and there's often a good reason for it.
Great, thanks. So that's a scenario where people have access to their clinical records. If they didn't have any of that and this person's completely new, is it maybe just a little bit of a longer process?
Yeah. Look, if this person is completely new to the surgery, you've never seen them before, you can have a look at, see if they're on My Health Record. That might give you some information to guide you, but you would probably need to spend a bit of time with the person, maybe a few visits, getting to know them, getting to know where they've been before, maybe getting their notes from their previous surgery if you can. If they've been a long time patient of a different surgery, maybe getting those records transferred over may help you. But for that scenario, it probably will take a bit more time to get to know the person and to make sure that their treatments are optimised as well for their mental health conditions. Because first and foremost, you're treating them for their mental health condition, and you need to make sure that that's being taken care of clinically as well.
Great, absolutely. We spoke a little bit earlier about the complex health issues, which we quite often see for a lot of people. When people do have a number of co-occurring conditions that interact with each other, how do they record that on a call?
Yeah, look, that is really hard, and it's going to be quite common as well. And often the person that you're seeing may actually be more bothered by one of their other co-occurring conditions than their mental health as well. I think the first thing is to work out the co-occurring condition. Is that also a disability? So often people may have more than one disability and can apply the scheme for both of those disabilities. So work out, are they both disabilities? If they're both disabilities, you need to do the access process for both independently. If one is a medical condition, try to minimise any reference to it in the access request. Sometimes it's actually easier if it's a medical condition, just to be able to minimise it. You don't have to worry about two applications. So if it is both, if they both are disabilities and you're going to be putting in a dual, they're going to be applying for access for both disabilities, when it comes to describing treatments, hospitalisations and impairments, you need to tease out which fits with which. So if they have an intellectual disability and a mental health condition, in your evidence you'll need to talk about treatments related to the mental health condition and treatments related to the intellectual disability. You will need to talk about hospitalisations relating to both separately. And also when it comes to describing impairments, if possible, try to tease out which impairments sit with mental health and which impairments sit with intellectual disability. I know that can be hard and sometimes they may overlap, but do your best. You will also need to complete two forms. So you'll complete the evidence of psychosocial disability, section A, for the mental health condition, and you will be asked to complete a supplementary information form for the other disability. They need to be kept separate. A person may get into the scheme for both, or they may get into the scheme for only one. So it's important that you try to provide as much information for both as you can.
Great, thank you. And in terms of establishing whether conditions, we've spoken through the 5 criteria as they apply for mental health. It's exactly the same for any other disability if people are trying to determine is this a condition, is this a disability?
So when it comes to other conditions, it's the same sort of thing. It can be an underlying medical condition, but if it has a permanent disability associated with it that has substantial impairments in one or more of those domains, it probably is worth applying to the NDIS for. When we talked about functional impairment tools, we talked about the LSP16, that is a mental health specific functional assessment tool. Other disabilities will have their own validated functional impairment tools, so you won't be able to use the LSP16 for a physical disability, for example. They will have their own functional impairment scores.
And it's probably important to remember that not just because it's a physical health condition, we quite often hear people going, oh, well, if we've got that, then that'll be easier. It's not always the case. But there are plenty of health conditions that have treatments that are available, and yes, they might be ongoing and challenging in some aspects, but they're not necessarily going to meet that criteria. So it is important to distinguish those two.
Very true. And a classic example is pain. A lot of people have quite complex pain syndromes, and that can be very tricky and is not always considered to be a disability, but often you will hear people talking about they've got a mental health condition and they've also got a pain syndrome. So there is a lot of guidance around how to deal with conditions such as pain and arthritis and other conditions that can be quite debilitating, but when do they become a disability? And I would really recommend having a look at some of the AAT rulings around pain and access, because they really do give you a lot of guidance on where to go and how to frame something.
Great. And what happens for someone who doesn't get into the NDIS?
So when someone applies to the NDIS, when their access application is reviewed, if they get an access not met decision, the access assessor will ring the person and explain to them why they didn't get in. So if a person comes to you and says they didn't get into the NDIS, I guess the first thing to ask is, do you think that decision was the correct one? Do you think that the person should have got in? If that's the case, if you believe they did meet all the criteria and they had enough evidence behind it to support it, the person can apply for a review of that decision. So they can go back to the NDIS. They can say, look, I know I believe I should be into the NDIS. You said I didn't get in because of this. Here's some additional evidence. So a person may come to you and ask for additional evidence to help support that review. If that internal review gets also access not met, again, the NDIS will ring them and explain to them why they didn't get in. The person can then make a decision about taking it to the Administrative Appeals Tribunal. At that stage, they'll be given a lot of additional support. They'll have advocates to help walk them through that process. And again, you may be contacted to provide more evidence or to explain the evidence that you have provided. So that's the first outcome. They might decide they should have got into the NDIS and they want to appeal it. If the person decides that probably the decision was correct, they don't need access to the NDIS. As a person with a mental health condition, if they were in one of the old Commonwealth programs, personal help as a mentor scheme, partners in recovery or day-to-day living, they automatically qualify for continuity of support, which means they will get funded support for their mental health condition, their psychosocial support, for as long as they need it. If they hadn't been accessing any other community mental health support prior to submitting the application, there are other programs available to them called the psychosocial support measure. They are funded through the PHN, and there are referral pathways that you can access through the PHN for those. So people will have access to other support. The NDIS is not the only option for psychosocial support.
And what about someone who comes in to ask you to help fill out an access request and you really don't think they're going to get in? What would be the best steps there?
That is really tricky, because we're seeing now that a lot of people are thinking, they're hearing stories about people getting into the NDIS and going on holidays and having house modifications and getting a cleaner, getting a gardener. So all of a sudden people are thinking it's something that can give them stuff. It can give them things that would make their life easier. I mean, I personally would love a gardener and a cleaner and someone to come in and help cook my meals because I'm busy. So I think it is really important, if someone comes to you who says, I want to apply for the NDIS, the first thing to remember is it's their right to apply. Everyone has the right to apply to the NDIS, and they should be supported to do so if that's what they want. You may want to explain to them what the NDIS is and how it is designed for people who struggle, who have substantial struggles every day of their life, and maybe have a conversation about why do they believe they struggle with their mental health condition, what does that look like for them, what can't they do because of their mental health condition. if they still insist that they want to apply, just be honest in your application. Provide the a summary of all the treatments you've done. Provide all the evidence you can, and just be completely honest. And that's all you can do. And if the person isn't eligible for the NDIS, that will be a decision that the access assessor makes. Sometimes we're surprised by who does get in, because some of the difficulties that they're experiencing you may not be aware of. People do, when they go to the doctors, they get dressed up, they make sure they've had a shower, they've taken their medications, they're in a really good, they make sure that they present really well. People with mental health conditions can hide from people that they respect how bad their day-to-day is, and you may be surprised by what happens behind closed doors that you don't see.
Yeah, absolutely. And I guess some clinicians may feel a little bit concerned perhaps about filling out this form for someone who they don't believe is going to gain access, but as we said, the decision is ultimately, it's the NDIS that makes the decision. It's not
your evidence will not sway a person in or out of the NDIS alone. It's a full picture of it. They will look at sources of evidence from a wide range. They'll be looking at the clinical evidence, they'll be looking at the evidence from support workers around functional impairment. So your evidence is one crucial part of a bigger picture.
Absolutely. And on that note, I guess in terms of the clinician evidence, absolutely clear, honest, accurate, and then let the NDIS choose whether or not they meet the criteria. But the clinician does play a really important role, and we often hear clinicians concerned that they put their statement of permanency in there, so this is likely to be permanent, I'm a medical professional and here's my statement. Yet they still need to provide a bit more justification around that, and they're not really sure why. Can we talk about that a little bit more?
Look, I think it's really important. The NDIS access assessors, when they are deciding if someone should get in the NDIS or not, they have to look at the evidence and match it up to the legislation. And they need to be able to say, yes, this condition is permanent, that treatments have been tried, these are the outcomes. They need to be certain of that. Just a statement from a clinician that says, I've been treating this person for 6 years, we've tried all reasonable treatments, this condition is permanent, that's not enough. You need to actually be able to demonstrate that those treatments have been tried and break it down so that when the access assessor checks it off, they can be certain that they have definitely, met that criteria and they have the evidence to show that they've met that criteria. So that's why you are asked to provide information around treatment, and you're asked to provide, a statement about what happens with each of those medications, just so that they can be sure that they meet that legislative requirement. And these decisions, the access assessors are audited on their decisions, so they need to be able to justify the decisions they make to their superiors as well.
Great. So I guess on that note of talking about medical evidence, treatments and so forth, some clinicians may have had patients or their support workers come in and ask for quite a lot of information from their assistants around their treatment history, because we know that sometimes people include attachments.
Yeah.
How would you advise clinicians who are perhaps concerned about sharing a lot of this information? I mean, you probably have access to all sorts of things, letters between clinicians, referrals, raw scores from psych assessments.
Yep, personal notes, Look, you don't need to provide the source documentation. You can summarise it. So in the evidence of psychosocial disability form, you can just summarise all the evidence that you have in your medical records. You can talk, you can just write who diagnosed and when. You don't need to provide the actual source documentation. As long as you can summarise what's in front of you, that is sufficient. So if you are concerned about privacy and concerned about having to hand over your medical records, you don't need to. Just a summary of those will be enough.
Great. And I mean, in some regards, people do have a right to access a lot of the information that's held about them, and that people may really want to see that. There can be some ethical concerns, I guess, in terms of how people may interpret the information without all of the resources around it. So maybe that's a good tip for someone who's asking for that information, is that a letter between clinicians taken out of context or without all of the background information that you can provide, it doesn't really help in any way
No, it doesn't.
for the application.
It doesn't. So you know, it wasn't written fit for purpose. Those letters between psychiatrists and yourself are usually often just you know, a debrief of what was discussed at the consult. It might be a discharge summary. It wasn't written to support an access application, and it won't have the information in it that would support an access application as well. And I guess that's why if you ever do get asked to do freedom of information, which sometimes has happened, you are given the option to redact anything that you think is important. And I think that that's because they recognise that sometimes those letters out of context are very easy to misinterpret.
And NDIA assessors aren't clinicians, so
no,
for some information, you know, they may get some assessment scores with that they can't interpret. So it's not useful to have that. It's definitely useful to have that plain language around it that has that clinician input.
Absolutely. Yeah.
Great. Well, I think that's probably we've covered everything that we wanted to talk about there today, Tania. I'd like to say thank you to Western Victoria PHN for inviting us to host this session. If you're in the Western Victoria region and you need to know more, there are some contact details on the screen there. And you can also email the email that's on the screen, gi@westernvicphn.com.au, or refer to the resources on their website, which is westvicphn.com.au. They've got a lot of great resources for health professionals, and they're definitely keen to help. We're also available to help whether you're in the Western Victoria or elsewhere in Australia. You're welcome to email us at transitionsupport@flinders.edu.au, and we'll do our best to answer your questions. So thanks again, Tania. That's all for today.
Thank you very much. No worries.
Thanks.
Thank you.
Bye.
Bye.